Lawrence.
Hi, Claire. I think they can hear me, but I'm not sure. I can't hear them. I don't know if you can.
Hey, we can hear you okay.
Oh, brilliant. Thanks,
Yeah.
Johnny.
Good morning and welcome everyone to the Kennett Room at County Hall for the July meeting of the Health Select Committee. I'll move straight on to item 1, which is apologies. Kieran, do we have any apologies today? I think we have.
We do, Chair. So we've had apologies from Councillors David Bowler, Howard Greenman and Pip Ridout, and also from Irene Kohler and Sue Denmark. Councillor Tom Rounds had been due to substitute for Councillor Ridout, but I understand he has come down unwell and has given his apologies as well.
Okay, thank you, Kieran. We'll move on to item 2 then, which is minutes of the previous... okay, Councillor Trevor Carbon, subbing for David Bowler. Thanks, Trevor. We will move on to item 2 then, minutes of the previous meeting. Is the committee happy for me to move that the minutes for the meeting held on the 7th of June 2022 as a true record? Thanks, Gordon. Any objections to that? No, that's fine. That's successfully moved. We'll move on then to item 3 on our agenda, which is declarations of interest. Are there any declarations of disclosable interest or dispensations as granted by the Standards Committee? No, fine. I'll move on then to item 4, Chair's announcements. First of all, just a reminder that as of last Friday, the 1st of this month, the integrated care system was formally established across the Bath, Swindon and Wiltshire area. I very much look forward to working with the Integrated Care Board, executive team, particularly Fiona Slevin-Brown, Wiltshire's new Director of Place. Over the last month, the Vice Chair, Councillor King, and I have been reviewing the quality of services offered by NHS healthcare providers within the county by reviewing their annual quality accounts. Responses have been sent to Wiltshire Health and Care, AWP, South West Ambulance Service Trust, who we'll be hearing from later on, and also Salisbury Hospital Foundation Trust, who are also joining us today. Finally, following discussions at our last meeting about the system pressures, I'm considering holding an inquiry day to consider the pressures on the system, particularly that issue of handovers at accident and emergency units. We do have the ambulance service talking to us today, but I think the possibility of an inquiry day is something that would be worthwhile and is something that I'm discussing with officers, so we'll update you on that in due course. Councillor Cape.
Just on that, I wonder if we should include delayed transfers of care in that. Absolutely. Thank you.
That's a key part of the discussion, and that would be included within that. Yeah, so it's a look at the whole system. Yeah, absolutely. Fine. So that's the end of item 4. So we'll move on to item 5, which is public participation. I'm not aware of any public participation today, Kieran. Is that the case? Fine. In which case we can move straight on then to item 6, the Salisbury campus scheme. And so for this, our first substantive item, we have Lawrence Arnold, Programme Director, who's joining us remotely via Teams. Lawrence has kindly provided us with a report today detailing the capital development opportunities being explored by Salisbury Hospital. So before I open up to the committee for questions, I'll first of all welcome Lawrence to the meeting. And Lawrence, I'll just hand over you to summarise the key points within the report. Thank you.
Thanks, Johnny. Can I just check that everyone can hear me?
Loud and clear, yep.
Brilliant, thank you. Hopefully you've all had a chance to read the paper that I submitted. The essence of this is that for those of you who know the Salisbury site, it's a very large site. It's got some very old bits to it. The day surgery unit is not the oldest, but from our perspective, it's the highest risk in terms of resilience of service. So the building was initially built in the mid-90s. It's a modular build, so always had a life of around 20-25 years, which has now expired. It linked to 2 pre-existing theatres from the 70s, and it presents to the hospital a risk in terms of its resilience. So we do have concerns around the infrastructure, and we do have challenges about maintaining the infrastructure, and it's not an uncommon frequency for either theatres or the whole facility to be out of action for a while, normally related to extremes of heat or cold, or sometimes due to problems with the roof and ingress from water. The complex has 6 theatres. It treats about 8,000 patients a year. It could probably treat more if it was more effective in its design. It's been built and then added to, so it's not the most efficient of buildings from a throughput perspective. And for the sorts of patients that tend to be what they call high volume, low complexity patients, we should be treating more patients than we can currently. So the business case has quite a lot in it about increasing throughput. So there is a need to replace the facility. We have got fairly detailed design work complete, and we've done the first business case that needs to be completed to access NHS capital. It's a 3 business case process. So we've done the first, what's called a strategic outline business case. The capital requirement is about £40 million, £41 million. And at the moment, we have no line of sight for that funding. So we're not on anyone's books for that level of funding. So in that sense, the business case, we're doing all that we can to make the business case as strong and as ready to go as possible, and that's part of the reason for coming to today. So I'll explain a bit more about that in a moment. It is part, as Johnny mentioned, part of a wider scheme for the redevelopment of the site, and we are in very initial stages of trying to do more with the site and having what we call a campus programme, which will bring other services on site, not necessarily healthcare, but potentially education, some life sciences and commercial activity. So there is a wider context to it, and we are very keen to use our wide, big estate as effectively as possible. We've done some engagement to date on that wider campus scheme. So we did events in Salisbury and Britford in 2019 and just explained to local people the challenges of our estate and what we were hoping to do to make it better. And then when we had some initial ideas, we did a virtual consultation exercise in August 2020, just to explain what we were thinking about. Both events were well attended by local people and were pretty positive in terms of the response. And the need for the replacement of day surgery featured heavily in those presentations, as well as the wider aspects. So as I say, this business case is in its kind of outline stage, but is ready to go when we think we've got access to funding. One of the issues that's been raised to us by NHS South West is the level of engagement that the Health Select Committee would like to see, and the level of consultation required given the service changed. And as I've described in the paper, the intent is to continue the current level of service, but just provide it in a different part of the site that's more accessible for patients, and that's more more better linked up to the main hospital. At the moment, the day surgery unit's a bit remote from the main hospital, and whilst that's not a massive challenge, if you've got the opportunity to make it closer to the main hospital, then that does bring benefits in terms of moving staff and equipment, and very rarely patients around the site. So the proposal is to move it to another part of the site, and that's the theme that we're working up and talking to Wiltshire Council planners about. So I'm happy to take any questions, but would be really keen to get a view back from the Health Select Committee on the level of engagement, level of consultation that you think that this project requires, and therefore the level of consultation that we need to undertake with local people. We will, of course, engage with local people on the design and the layout and the approaches that we take. But of the scheme. Really happy to take comments and questions and feedback, please.
That's great. Thank you very much, Lawrence, for that. I'll open up questions in a moment. Just on this point of the Health Select Committee giving a view on the requirements for public engagement, I'm not sure it's appropriate for us to give a definitive steer on that, because it would very much depend, I suppose, on the nature of the funding opportunity that you might be applying for. That might have requirements for public engagement. You know, I note it is the relocation of the same service within the site, but there are potential impacts on car parking, which is always a matter of public interest when it comes to our hospitals. So that might necessitate engagement, but I don't think it's appropriate for us as a committee to give a definitive response on that particular question. But I'll open up to the committee now for questions. Did we have any questions from members of the committee for Lawrence? Mike, Councillor Sankey.
Thank you, Chair. This might sound like an obvious question, but if this was a modular building provided in the 1990s with a limited shelf life of 20 years, I'm just curious as to why a funding stream hasn't been chased prior to now in anticipation of the required replacement.
This is something that we've been pushing for about 3 or 4 years. So this is not new, but this is a function of the availability of capital. So we put bids in for capital. Probably the first one we submitted was about 4 years ago. So it has been something that we have been kind of keen to do, but it's not always too easy to secure the level of capital that's required for schemes such as this.
Councillor Carbon and then Diane.
It's this point in the conclusion where it says, paragraph 512, does this constitute a substantial reconfiguration? Is there some kind of definition of what a substantial reconfiguration would be? And is it simply a geographical term, or does it mean the level of service and so on as well? Basically, what does that mean, and how do we know what we have to do about it?
Something I can talk to NHS South West about. I think they see it as something that that it's for kind of local people and local systems to decide. So actually why I brought it here today. If there's somewhere else I need to go to take it, then obviously happy to do that.
Yes, and I think that comes back to my point as to I'm not sure it's appropriate for us as a committee to define what a service reconfiguration is. I think, again, it would depend on the nature of the funding stream you're applying for, I suppose. So but I'd be reluctant to sort of push the committee for a definitive steer on that today. I'll hand over to Diane, who had a question, and then Councillor Cape, and then Councillor Vigar.
Okay, thank you very much. Mine is really more about some of the points that are in particularly case for change that you've put. And I was interested in knowing that you will continue all of these surgical specialities and would increase to 6 general anaesthetic theatres, but no local anaesthetic theatre. And that was one question. And I wondered why. What's the reasoning behind that?
So the general anaesthetic theatres, you can still do local anaesthetic procedures. The reason for having all general anaesthetic is to ensure you've got flexibility to be able to use the theatres for either general or local anaesthetic. So it just gives more flexibility to the surgical teams when they're booking theatres, when they're organising patients. At the moment, we've got 2 theatres that can only be used for local anaesthetic, which means you're constrained in terms of the availability of general anaesthetic. So it doesn't preclude local anaesthetic procedures being undertaken in the facility. It just means you've got greater flexibility. Hopefully that makes sense.
That's fine, thank you. I can understand the greater flexibility. The other one was about the there are insufficient facilities for children. And I wondered, what will you be offering extra in this new facility for children?
So dedicated facilities for children. So at the moment, all of the admitting areas and the recovery areas are which means that we have to pretty much either manage children on particular days, so have no adults going through the day surgery unit at the same time, or admit some of the patients through our inpatient ward and then take them to day surgery. So it's pretty inflexible. So again, so in order to increase that flexibility, we will absolutely have dedicated admission areas for children. We have dedicated recovery areas for children, and be able to return the patients back to where they were admitted for their discharge, again in separate areas. So completely separate flows between adults and children. And to be honest, that's a requirement for the design of new facilities these days in the NHS. It just wasn't when created.
Okay, thank you. That was it.
Okay, thanks, Diane. I had Councillor Cape next.
Thanks very much, and thanks for updating us on this. As in a previous life, I did manage theatres and day surgery, so I do understand exactly what you're trying to do here. I just wondered if you'd like to comment at all on the likelihood of increasing the proportion of surgery done as a day case. I know that's been the drift, if you like, over the last, well, since the turn of the century, if not before, and whether you're expecting that to continue and how that's been built in. Thank you very much.
The question, that's the essence of what we're trying to do. So it's an absolute fundamental, and because of some of the challenges with the current environment, we can't do as many procedures as on a day case basis as many other hospitals can do. So we're at the lower end of the day case rate. So just to give you a good example, we have no laminar flow in our day surgery unit, which means orthopedic cases, big orthopedic cases, can't be done on a day case basis. So that's one of the things that we absolutely will want to have in the new facility, and are looking to have at least 2 theatres with laminar flow. So absolutely, we believe that for the majority of patients, day case surgery, and for many procedures, day case surgery is kind of the best possible option. We're absolutely looking to try and increase the proportion of patients that go through day surgery, not least because you were talking about the emergency pressures earlier on. That has a big impact on elective surgery, and the more patients that you can operate on through a dedicated day case facility, it means the impact, it just substantially reduces the impact of those emergency pressures on the elective care pathway. So it absolutely underpins what we're trying to do here.
Thanks, and I'm sure that trend will continue. Thanks.
Okay, thank you. And Councillor Vigar.
Thank you, Chair. So, yeah, from my point of view, reading this, it appears that the clinical case is well made and the business case is well made. So that's kind of, I think, taken as read in my view. But I just wanted to follow up what you were saying, Chair, and what Councillor Carvin was saying. Is I'm not entirely sure of what this committee's role is, what we're being asked to do here. I'd like to ask you where you see this meeting being in the whole process of getting this facility up and running, because like Classic Club, and I noticed on the report the mention of this committee giving a steer as to engagement, and I noticed the chair saying that might not be appropriate because of the sources of funding. So that leads me to ask perhaps the obvious question: am I blundering in here? What are the likely sources of funding? And in terms of those sources of funding, what are they contingent upon in terms of engagement? There seem to be 2 things said in the report. One about it being a substantial reconfiguration, that being some kind of threshold, and something about the nature of engagement. I'm trying to fit those jigsaw pieces together to understand exactly what we're being asked to do here.
absolutely not undertaken anymore, so there aren't any capital schemes being funded in that route. So the most likely is public sector capital. It may well be that that there may be other sources of funding that we may be able to attract for this scheme because of the links to the other elements that I talked about around the campus, but that's unproven at the moment. So as we sit here today, the only viable funding route is public capital. And that's, as you'll be well aware, is challenging in the current economic environment. So we're continuing to bid where we can, where there's opportunities. We continue to raise the issue and our concerns about the resilience, and we continue to lobby for that we believe that this is something that Salisbury needs, and address our concerns about the ongoing resilience of the facility. All of that ongoing and is what we're doing. The point of the business case and the reason why I've brought it here today is firstly to make sure that you're aware of what we think the hospital needs to do in terms of developing its services and ensuring the resilience of its services to local people, and to be in the best possible position. So our business case that we've written, because there's no source of funding, we've effectively written it at risk. And the reason why we've done that is to be in the best possible place to go to the centre to say, we have a business case that we think, and it's nice to hear this, meets the case for change, is consistent with national trends about the delivery of surgical care, is underpinned by something that we know that we could construct because we've got a fairly well-formulated design, and that we've been talking about the planners about where we would like to build it, and essentially, without going too far, there are no major concerns about that. As I said at the outset, one of the things that was raised to us by NHS South West was getting the view from the Health Select Committee about the extent of change involved and whether that gave cause for concern, which meant that we should be consulting with local people about what we're doing. That was the point of bringing it today. If there's more work that we need to do to describe that, or if there's some other route of achieving that aim, and ears on that would be really helpful. But just being absolutely clear, at the moment, our focus is on having a business case that we could present to the centre literally next week if the centre asked us to do so. So that's the reason I'm trying to get the business case in the best possible position. I hope that makes sense.
So all I'd say as a supplementary is I saw that you'd done a survey of local people, generally local residents. Maybe there was something I missed in there, but I think the views of local GPs and local patients who've actually experienced surgery maybe would count quite a lot for a particular kind of constituencies.
We certainly we've done as I said, we've done some engagement with local people, and they understood what we were proposing and our reasons for doing it. Local GPs have been very supportive. Obviously, they're big users of service, and some of the GPs that have been involved in the campus project have been very supportive of the scheme.
Great, thank you. Were there any further questions? No? So I think, Lawrence, thank you very much for the update. Now, I just think on that question of whether we define this as a substantial reconfiguration, I think it's not really for us as a committee to make that judgment. However, the very fact that you've brought this to us today to update us is welcome. This is good early engagement with us as a committee. and we'd certainly welcome further updates going forward as and when funding opportunities become available. But I think in terms of NHS South West, I think probably the best thing for you to do is to go back to them and say that you have engaged with us and we welcome that engagement. But it's not really appropriate for us to set definitions as to what is a substantial reconfiguration and what isn't, and therefore what level of public engagement should or shouldn't take place.
Okay.
Are there others in the committee happy with that? Yeah. I have a question down there. Sorry, a question from Councillor Carbon.
Not really a question, just a comment on that proposal that you've made. Can we maybe be a bit more positive? This is something which is clearly in the interests of patients, residents and the hospital community generally. So for somewhere we could get in that the Health Committee supports the concept and would like to know more about the detail, and if we could, give it our firm support, and that again might help with the business case and all the rest of it, the things that we heard. So a nice positive take if we can, Chairman.
Absolutely, that wasn't a proposal. I was just summing up the debate really before moving on to a proposal, but that's noted. Absolutely, Councillor Cape.
Yeah, just perhaps to add that we welcome the engagement that's already taken place, and would expect the hospital to continue, the trust to continue along that line. Thank you.
Great. Were there any further questions then before we do move to a resolution? No? Fine. In which case, I will resolve that we thank Lawrence, the Programme Director, for the update. We note that the business case for a new elective care centre is at an outline business case and is supported by the Health Select Committee. To welcome the engagement undertaken with the public to date, and also to welcome the engagement with us as a committee, and to request an update to the Chair and Vice Chair of the committee when the programme team has a line of sight to future capital funding. But overall, Lawrence, it does seem like a very positive thing, and thank you again for bringing it to us. Do we have a second for that? Thank you. Any objections or further comments? No, thank you very much. Thank you then, Lawrence, for bringing that to us today, and best of luck with it all as it moves forward. It does sound like a very positive thing for the hospital and for healthcare provision. We'll move on then to item 7, which is Wiltshire Independent Living Strategy. So in advance of its consideration by Cabinet in September, the committee now has an opportunity to review the draft Wiltshire Independent Living Strategy. We have Helen, Robert and Councillor Jane Davies with us today. So I'll hand over to you to introduce the draft strategy, and then we'll open up to the committee for questions. Thank you all.
Thank you very much, Chair. I'm very pleased it's been a positive meeting so far, and I'm hoping that we can continue that, because this is a paper that I'm very pleased to be bringing to you today for discussion and feedback. And also, I think I'll be very pleased to take to Cabinet in September. In Wiltshire, we have made significant improvements in recent years around improving outcomes for people with learning disabilities and mental health needs and people with autism. However, we have identified that there's still a lack of choice, quality and consistency around our local housing and social care markets. And this means that too often Wiltshire residents are having to move outside the county or to care settings which are overly restrictive in order to have their needs met. Now, it is a draft paper that you've been given, and I did notice there was a typo. I think it's in paragraph 5, which implies that we do want people to be in overly restrictive care settings. And obviously that's really not the case. We want people to have as much independence and choice about their lives as possible. The strategy represents an ambitious programme of work for the council with its partners. And we've worked with a range of stakeholders from within the council, commissioning, social care, housing, education and planning, and from health, the BSW Clinical Commissioning Group and our key providers, AWP and Oxford Health, the NHS Foundation Trust, Wiltshire Health and Care, and the voluntary sector, including the Wiltshire Centre for Independent Living and the Wiltshire Parent Carers Council, as well as the independent sector, including the housing and social care providers. The implementation of the strategy will form part of the Adult Social Care Transformation Programme. It's a complicated area, as you can tell from the number of stakeholders we have involved in it. As it succeeds, and we will really work hard for it to succeed, we expect to see fewer Wiltshire residents in out-of-county placements, people spending less time in hospital because their needs can be better met in the community. Customers will be involved at every step of the commissioning journey. We've done quite a lot of consultation with the people who use these services, and that's part of a cultural shift where, nothing about us without us. We are listening to people. We also want to provide clearer, more accessible information to the public about what is available and what the processes are for applying. We want more people to have tenancy rights and fewer people to be in residential care. And we really want young people to feel confident about their future and feel prepared and supported as they reach adulthood. So the committee is asked to consider the strategy and support its ambition to maximise the independence, choice and control over their own lives for people with learning disability, mental health conditions and/or autism spectrum conditions in Wiltshire, and to do so by providing the right accommodation and support at the right time and in the right place. Thank you. Our leave officers will have details, which I'm sure they'll offer you.
It's up to if you'd rather sort of handle it in terms of response to question, that's fine. Yeah. Fine. Well, in which case, Jane, thank you very much for introducing this. It certainly seems very ambitious and great to see that people are really at the focus of this. So it seems a very exciting piece of work. So I'll hand over to the committee for questions. Do we have any questions? Councillor Carbon.
There's nothing about the budgetary implications in the report. Is this what's it going to cost, or will it have a benefit?
I mean, I think over. That looks better. So certainly in the long term, I think we would expect this to save money, because when we look at people, particularly adults with learning disabilities, we know that we've got more adults of working age with learning disabilities in residential care than we would expect. And residential care tends to be both more expensive and also it provides less independence than an independent tenancy in a supported living unit or in general needs housing would. And I think because of the gaps in the market that Jane described in Wiltshire, we're also still in a position where more often than we would like, people are having to move out of county, away from their family and friends, away from their networks, from the services that they've been receiving. And that is happening a lot less than it used to. And the culture, I think, in the last 3 or 4 years has changed a lot, and we're moving towards a much more enabling sort of culture. But we're still in the position too often that people are having to move out of county. And when you look at out of county placements and compare them to similar placements made in Wiltshire, the out of county ones are more expensive. So we may need to invest in, if we're going to, the strategy sort of sets out that at the moment we don't have the right sort of accommodation in Wiltshire, or not consistently anyway, and not in the right places always. So there may be some investment needed, both in terms of housing and in terms of support. But I think long term it will both save money and really dramatically improve people's independence and their outcomes and their sort of opportunities.
Thank you very much, and good morning both. I'm quite supportive of this paper, particularly with its emphasis on independence and responsibility. But these are nevertheless vulnerable people, and I'm just wondering, as we move people to give them more rights, including tenancy rights and housing options, including more financial responsibility, what close support we will be giving those people in terms of guidance to help them make right choices going forward, so that they don't become victims of a change, but survive within that change.
I think Claire might be in a better position to answer that than me.
Thank you. Yeah, so they would still come into adult social care. They would receive a Care Act assessment to determine their eligibility. And within that, we would design a support plan and make clear kind of what the support needs were for that individual. What Robert's report really is describing is kind of improving people's choice and ability to live as independently as possible. What we've got at the moment is, sadly, a situation where we're heavily reliant on residential care for working age adults. And that's quite an out-of-date model, which is one that we need to move away from. And the reason for that is that really we've recognised in social care, and indeed regulators such as CQC, that individuals, particularly with learning disability, autism and mental health conditions, can live really successfully in the community just with additional support. So they would still, as I say, come into our services. We would determine the level of need. We would be around to support them with reviews of that need, and if necessary, provide a level of intervention as well. So that particularly sits very much in how we work in mental health, for example. So we wouldn't necessarily put in a lot of paid for care and support for somebody who may have functional mental health disorders such as schizophrenia, but they may have an allocated social worker, they may still have a tenancy and a level of support around that tenancy to maintain that tenancy. So all those things are in place, they're just not being maximised. And what we need to do, and that's part of the strategy that Robert's designed, is really to focus in on how we can develop the services that we've already got and move away from a model where we're institutionalising young people so that they can continue to live in our society and in our communities. So it's a really exciting opportunity, I think, for Wiltshire to move forward and hopefully, as Robert says, to maximise independence, but also to recognise that this is actually quite a cost-effective way of running services, and hopefully we'd be very much in the best interest of the service users and indeed their families and carers.
Jane, did you want to follow up on those points?
Yes, I did want to say something to Gordon, which is this isn't just about reducing the amount of residential care. I mean, we have a cohort of young people who are living with ageing parents who obviously, as their parents' health declines, won't be able to support them. And so those young people really need to be supported into independent living and established at stability whilst their parents are still able to contribute to that and they can be part of the community. So there are a variety of groups and drivers in this who we're looking to support. And the feedback from places like Wiltshire SIL and Wiltshire Parent Carers Council is that it is a well thought out and quite a nuanced approach that we are taking.
Thank you. Councillor Champion.
This is just a question as me as a councillor. I mean, several times this week I've had people phone me up with their various problems. Now, how can I help them? I really would like to know. Some are so desperate. They're sofa surfing, they're doing different things. There's one person who's trapped in a 3-story building and can't get down the stairs. There's no lifts. How do I help them? That's all I'm asking.
Claire, I think, got a hand up?
Can you hear me okay? Yeah, so Obviously, we have Advice and Contact, which is our front door into adult social care. It is quite challenging, I think, for elected members to make referrals into adult social care. We do recognise that, and that is because we are very clear around confidentiality and consent. So where someone has capacity to make their own decisions, we respect that they must make those decisions themselves. And sometimes that can be quite challenging because we recognise people can make some unwise, or what we might perceive to be unwise decisions. So it is difficult. But what we would say is we would urge you to recommend that people contact Advice and Contact. We can often speak to yourselves or a family member if the person is there alongside you. So really make contact through that. And obviously we're online. Our website is really clear about how you can seek advice. So Advice and Contact supports that initial front entry into adult social care, but it's also a signposting service as well. So if it's not for adult services, they can help and signpost you to community-based services or indeed housing, for example, as well. So really, first port of call I would suggest in cases like that is to try and make contact with Advice and Contact. Does that help?
Councillor Sankey?
Thank you, Chair. To answer the question that was just put, I think as members, one of the best ways we can support our residents is to support these recommendations we have before us. I'm looking at the 5 recommendations on page 23, and I think they're all something that we should all aspire to, especially when you consider things such as our responsibility as corporate parents. A lot of these people are young, and we have a responsibility to them to send them forward into their adult life. So I have no hesitation or problem whatsoever in supporting the 5 recommendations before us.
Thank you, Mike. Councillor Vigar.
Thank you, Chair. I spent some time as an officer and a fundraiser, a member of West Wilts MENCAP, so I've really recognised the syndrome you're talking about, whereby parents look after somebody with learning disabilities or other difficulties, and it carries on until the parents get themselves quite elderly. I understand there are other young people whose parents choose not to look after them, and therefore they go into a residential care or independent living or whatever. Is there any process by which you try to find those who may be a bit hidden because parents are looking after them but struggling? That's my first question. Second question, I've read all this and I see the line about doing things differently or doing things in a different way, which I never quite follow as to exactly what that means. When you talk about reorganising the framework, does that actually mean you're going to refresh, to put it politely, the providers, and you're looking for a different set of providers? I wonder if that was hidden in there. And thirdly, what part do you see shared lives playing in this? I saw there's a mention of it in the report. Everything I've seen about shared lives suggests to me that it's a great success, that it works for the carers, the cared for, and the council in terms of finance. So, yeah, throw those 3 questions if that's okay.
Thank you. So, first of all, in terms of whether there's a process of sort of identifying those people who are currently living with parents and that might not be sustainable, there is a process. There's a process that we have in adult social care of identifying which people are either ready to move, so we've heard from some young people, they're living with parents, and actually in some cases their parents might think we want our children to carry on living at home. But the children, young people in their early 20s are saying, actually, we want to live independently. So we've got a process for identifying those people and planning where they're going to move to, but also kind of older adults, adults who might be be middle-aged and living with parents who are now becoming elderly. We're doing an exercise in adult social care to identify those people as well, where they might need to move in 2 or 3 years' time. It's not necessarily just the people who need to move now. It's trying to plan for the future as well. And in terms of working in a different way, so the framework bit of that, the Good Lives Alliance framework runs out. The contract runs out next year, isn't it? Yeah, it runs out September next year. So we're beginning to sort of learn the lessons of the Good Lives Alliance framework, think about how we might do things differently, because one of the things that's happened is we've got about in excess of 70 providers who have joined that framework, but quite a lot of them, they never bid for any work. They're kind of almost dormant providers. And from a commissioning point of view, we've got all these providers, but we haven't got the real kind of quality, the real specialist providers that we want. So I think we want to take an approach where, rather than having loads and loads of providers, we want to build some strategic partnerships with those providers who really share, our vision and our values and our sort of way of doing things. I think the other thing just to add about that is that kind of, and I think this kind of plays into your point about shared lives, that at the moment the market isn't consistently doing what we want it to do. And that's both the housing market and the care market. There's some good provision out there, but it's not consistent. So if we just wait for the market to respond to what we want, that might not be the best way of doing things. And shared lives is a way of us as a council modelling, a different way of doing things and a much more enabling way of doing things. And the intensive enablement service within adult social care is also a much more kind of re-ablement focused, independence enhancing way of doing things. And I think we need to build on that and kind of model what we want so that the market can look at what we're doing and say, okay, that's what we need to do. This is an affordable way of doing it.
Yep.
So I noticed there was a bit of promotion of shared lives a couple of weeks ago where they had some stalls out in parks and so on. Are we going to see equivalent energy put behind recruitment of shared lives carers as we've seen with foster carers, for example?
I'll get Claire to answer that.
Robert. Yeah, and thank you. So apologies, I didn't introduce myself, but I think most of you might know me, but I am the director of Whole Life Pathway and Shared Lives does come under me. So in some local authorities, Shared Life is out in and is run by a provider. In Wiltshire, it is within the council. So it's an in-house service that we have, and we have a head of service called Caroline Bowen, who has a number of community services under her remit. So yes, we are really passionate about shared lives here. We've done a huge amount of work. There's been significant investment actually into shared lives in the last couple of years, because we do recognise the importance it can play, particularly in terms of the independent living strategy. We do also recognise that it hasn't necessarily had the communications and marketing that, say, for example, fostering has had. So we are working on that at the moment, and we're hopeful that that will improve. I think there is a real challenge in terms of attracting and recruiting carers, but in the last 2 to 3 years, and including through the pandemic, we were actually seeing an increase of carers joining us, so that's a positive. So we do recognise we have to be very proactive in attracting carers to join shared lives, and that is a piece of work we are doing at the moment. So yeah, and thank you for raising it, because it is something that once it gets raised, it's a really good topic to start talking about what it is and how it impacts on people. But in Wiltshire, it is a really successful scheme, and we do want to continue to grow it. Thank you.
Thanks, Claire. And I think Jane just wanted to follow up on that.
I did. I wanted just to say that Shared Lives Wiltshire has a fantastic Facebook page, and if you follow them, you can share a lot of their posts. So I'd highly recommend that all councillors have a look at that and share on Facebook.
Thanks, Jane. Councillor Cabe, did you have a hand up? You did.
Yeah, thanks for those comments about shared lives. It's good to hear. My question might seem a little bit off topic, but I just wondered if there's anything we can do around the market where developers bring forward applications for basically retirement-only developments. And my thinking is something a bit more mixed can be better for people who live in those developments. I've seen something in Chester when I was up there about 6 months ago, where the ages were mixed and residents were able to be much more supportive of each other. There seems to be a lot of retirement-only applications coming forward, and I, like I say, appreciate it's not quite on the point that you're making here, but whether there's anything that could be considered along that. Thank you very much.
Helen, are you trying to log in.
No, I like you, have reservations about retirement homes. I think there are national planning legislation that we'd have to tackle to do that. But I personally think it's a very good idea. And in my division, Astor are redeveloping an existing sort of block of flats that they have. And one of the things I'm going to ask them to do is include, mixed age groups and hopefully support some of our local people who need accommodation. So I think it's a good point.
The other thing that we are looking at, which is mentioned in the report, is the use of extra care housing. So traditionally, we have used it for people as a sort of preventative measure to stop escalation to care home provision. And actually, we have found the extra care housing has probably had limited impact in terms of that. And so we're going to look at the potential of mixed usage around extra care housing. And actually, could you have a more mixed community rather than a retired community trying to prevent going into a care home? So that is something we're looking at.
Thanks, Helen. Any further questions? I don't know if any others. I just wanted to ask, I think it's a really positive thing. Oh, sorry, Councillor Jackson.
Thank you, Chair. We have an organisation in Warminster which closed last week called Warminster Adults Valuing Everyone, providing care facilities for people with challenging learning difficulties. I'm just wondering whether or not that is going to be replicated elsewhere, and whether or not that system is going to be more inclusive. In other words, whether these activities can take place within the community or amongst the community rather than discreetly behind closed walls, barriers, locked doors, whatever. Thank you.
I think Claire wanted to respond on that one.
Thank you. So I think, are you referring to the Wave in Warminster? Yeah. So the Wave is one of our day opportunities. Again, it's an in-house service that we run within the council, and it comes under Caroline Bowen's community services. We haven't formally closed the Wave. We have to recognise that the building that the Wave currently operates from is no longer available to us. So we have to do a buildings-based review and consider options around the facilities in Warminster. So individuals who attended the Wave, of which is quite a small group, have got the opportunity to come here to the Medley, which is the day opportunity in Trowbridge, and also the Meadows, which is the day opportunity in Salisbury, until we can establish the next steps in Warminster specifically. However, the point that was well made around community access for day opportunities is very close to my heart, because we do have, as people are aware, a number of building-based day opportunities for people with learning disabilities. And I think respectfully that the point around people being in those buildings and not out into the community is absolutely valid. And again, it's something that we're working tirelessly to kind of unpick and understand what community services that aren't buildings-based should look like, that they're safe, that they operate well, and that individuals who have complex needs, including physical needs, are well served. So we do recognise the cohort of people that we work with within the in-house services. A number of them have quite high levels of physical need as well. So they will often rely on a building and to be able to go to and meet from, etc. And indeed, obviously, if the weather's bad, etc. as well. So part of adult social care transformation, which people are probably familiar with, that we're looking at right across adult services, because we have to consider the new adult social care reforms coming, is also to look at how we can improve our in-house offer. We've also used, during the pandemic, some savings that were made because our building-based day opportunities were closed due to infection control regulations. The money that we saved, we actually reinvested in our in-house learning disabilities and autism offer and developed a community outreach and enablement service that continues to run. So some of our service users who were restricted by building-based now access the community through that service. So our plan is, wherever possible, is to do exactly what Councillor Jackson's just described, really, is to continue to review, develop and improve service offers alongside our service users and their families. And I'm more than happy to come again in the future if it's of interest for people to have a conversation around our in-house offer. Obviously, Helen and Robert are very much focused on the market. I have the operational teams, but I am more than happy, like I say, to come again and describe to you what we currently have, and indeed some of the conversations we're having with our service users, families and voluntary and community sector organisations as we continue on a sort of improvement journey. So I hope that helps.
Thank you, Claire. Yes, and I'm sure the committee would appreciate that further update. So thank you. I didn't see any other hands. I just had a sort of brief question or observation. It's good to see that this strategy has been developed with input from a wide range of stakeholders. I just wondered, to what extent is it informed by experiences in other authorities? Are there similar strategies being undertaken elsewhere? And I know each authority is different in terms of the needs of their populations, but just as a point of interest, really wondered if this is informed by experiences from elsewhere and learning from other areas.
Yeah, it has, particularly other local authorities in the southwest. So there are fairly regular ADAS kind of get-togethers of commissioners, both housing commissioners and social care commissioners across the southwest. So we've shared where we've got to with some of our partners in the southwest, and have had examples of other strategies, both in the southwest and from further afield, actually. So yeah, we're kind of keeping an eye on what others are doing. Yeah.
Thank you. So if there are no other questions, we'll move to a resolution to thank officers for the report and to welcome and support the recommendations of the strategy as captured in paragraph 19 of the report, and to invite further updates to the committee on the future delivery of the strategy. So could I have a seconder for that? Thank you, Gordon. Any objections to that? Great, that is moved. Thank you, officers and Jane, for the update. We'll move on to, as I just throw pens around, sorry, Kieran. We'll move on to item 8 of the agenda, collaborative working with providers. So we have a report in the agenda papers which analyses the impact of support that has been provided to the adult social care market in partnership with Wiltshire Care Partnership and the former CCG. I think we have Joe Howes, who's the CEO of Wiltshire Care Partnership, joining us remotely. Welcome, Joe. Can you hear us? And
Thank you for
great.
having me. I can hear you. I'm trying to turn my camera on.
Thanks, Joe. Okay. And I think we have Tanya with us today, and I've got Emma Legg here, but I don't think Emma's with us. Is Emma's there? Sorry, Emma, I didn't spot you there in the corner, to introduce the report. So, Tanya, if you'd like to summarise the salient points, then we'll hand over to the committee for questions. And Jane, are you going to introduce this one? Okay, apologies.
Yes.
Thank you.
Sorry,
Jane.
Anna, I don't know. I don't want to steal your thunder, and perhaps you can follow me if you've got particular comments and something I don't mention. But again, I wanted to say that I think this is a positive paper. It shows the way that we're moving towards working with providers in the market to ensure that we have resilience and strong market sustainability. And this particularly relates more to care homes, etc. But they have faced enormous challenges during the COVID pandemic and continue to do that. So we want to have a way of working with them. And I really want to praise the officers for the support they offered to providers, particularly during the pandemic, but as an ongoing service through the provider oversight and support team, the post team. You'll have seen when you read the report some really excellent feedback in points 8 and 9 about how well this partnership approach is working. So I will leave it now to the officers to talk, but I wanted to ask you to welcome this report, please.
Thanks, Jane. Well, we'll hand over to officers then.
Thank you, first of all, for the opportunity to speak to you all today. Our provider oversight and support team was a direct result of the COVID pandemic. It's probably one of the only positive things that did come out of that pandemic is that development of the relationship with our providers and the opportunity for us to offer early intervention, both into outbreaks and into other situations, and the development of trust and partnership working with our providers and with Wiltshire Care Partnership. So we've had some fantastic results. We've had some really good feedback. We've had the opportunity to be involved in development of a strategy that worked with health and our provider colleagues that directly resulted in the reduction of home closures, which had a massive impact on the backlog of beds being closed in the hospitals. We've also looked at financial grants, and the 17.5 million government grants were facilitated through the provider oversight and support team. And going forward, we are now finding that our providers, because we've built up that relationship, because we have that trust, they come to us first. So as soon as there's a problem, as soon as there's advice needed, they come to us, whereas before they might have waited until things had gone drastically wrong. We're able to have those early conversations, signpost them to the appropriate people, or indeed intercede on their behalf. And that's something that we're particularly passionate about within the team. It's something that we're starting to do within the payments to providers project that we're doing, which is looking at how we make sure our providers remain financially viable, that we look at resolution of any outstanding provider queries. And by doing so, we have, perhaps I would dare say, have won over some of the providers who maybe were a little bit apprehensive to start off with, but when we were asked to take on the project, the first thing that we were told was that actually we were the ones that they trusted the most to take it. And I think that can only be seen as a massive benefit.
Thanks, Tanya. Helen.
Chair, Joe might want to say something as well, because I just wanted to emphasise that actually without the collaboration with Wiltshire Care Partnership, we wouldn't have been able to achieve what we did, and also with our health colleagues. What we did is, in Wiltshire, quite uniquely, we enabled this post team to be almost like a one-stop shop for providers throughout. And so health collaborated very closely with us, as did Emma and Claire and their operation colleagues, to ensure that main communications queries came through the post team, and so that providers weren't being bombarded by different communications, because at the time there was different communications coming in nationally, almost daily, and quite a lot of which needed interpretation into plain English, and for providers to have a clear understanding of where the legislation may or may not have changed. So without the collaboration of Operation Colleagues, Wiltshire Care Partnership and Health, the post team wouldn't have been able to do what they did. And Joe may want to add to that from a provider perspective.
Thank you, Helen. Yes, indeed. Joe, it would be very interesting for the committee to hear from the providers. So I'll bring you in at this point before we open up for questions. For any comments?
Thank you. Do I look a bit, am I on a big screen, or I do look a bit like the Wizard of Oz, so apologies. I had heard that might happen. I mean, I think providers really welcomed the post team. It was the positive thing that came out of the pandemic. And I mean, although it was a team facing the providers, it was able to draw on all of that other expertise, and also from public health as well. So if public health input was needed, it went through post, and it was just so valuable. I think the thing I would say from talking to my colleagues around the country, which is probably useful for members to know, is that didn't happen everywhere. There were local authorities around the country who didn't offer any advice and guidance, particularly to their providers. And I think Wiltshire stood out as a beacon of how to do that properly. And, you know, it's probably something that should be recognised more, and that you should blow your own trumpet about more, because it felt really different in other parts of the country. So I suppose that's, you know, the main thing I would take away is that it added value at the time during a really horrible time, And it's a really worthwhile thing to maintain and continue, because that relationship between providers, going back to what Rob said previously about wanting to commission a sustainable market, you only get that through understanding what it is the council wants to achieve and where it wants to go over a long period. If you're running a business and delivering a service, you need to know what the expectation is that will look like in 5, 10, 15 years time, and having people that you can talk to and collaborate with is what makes that possible. So I've got only positive things to say about that collaborative work.
Great, thank you, Joe, for that. I'll hand over to the committee now for any questions, of which there don't appear to be any. Gordon.
I don't have a question really, just a comment. It's a great example, of what this committee have expected for a long time, greater collaboration between the various parts of the system working well together, achieving great outcomes. And I echo Joe really, if this really is a beacon, we should shout it loudly and do that. So really well done all, really.
Absolutely agree. Thank you, Gordon. Any others? Councillor Vigon.
Sorry, as a newbie, there were a few things that I didn't quite get. The feel of the report is fantastic, and everything that's been said by the providers clearly shows that what's happening on the ground is terrific, and that's brilliant. But could you just explain what actually changed when you adopted this collaborative approach? Presumably you collaborated to some degree with providers. There wasn't no collaboration before, and in particular the payments to providers. What are the payments that were happening with the collaborative approach that were not happening without the collaborative approach?
I wouldn't like you to think we weren't collaborating before March 2020, and it took a crisis to enable it. But I do think, and I think Joe would agree with me when I say it accelerated the relations that we'd already established. And I think you saw really co-production in action daily. So you said about the payments to providers. We didn't do, so we had national criteria that we followed, but within that criteria, there were a lot of nuances and there were a lot of options that we were given. So we co-produced with providers, with Wiltshire Care Partnership, every grant that came in, what criteria we were going to apply, where the money was going to go, what we wanted to see the money spent on. So that level of granularity of collaboration. And it was really good because we were able to say to providers, and I think a lot of local authorities came under a lot of flack on how they use their powers of discretion in terms of the funding, but we didn't in Wiltshire because we could truly say it was from us. Joe and I jointly wrote several letters to providers during the pandemic, particularly around if legislation had changed. And we also did that as well with Kate Blackburn. So I think we became more mature in our joint working, and I think we really saw collaboration in evidence in everything that we did. We didn't do anything as a local authority without collaborating with Wiltshire Care Partnership and providers wider first before we did it. And therefore it was owned. It was, I think, providers felt they were owning it as well as the local authority, and it was being done with them and not done to them. But Joe might want to add more to that.
I think I'd really agree with that. And I think also that kind of co-production collaborative approach has made it easier to have more difficult conversations. We're moving back into a sort of business as usual time again now, thank goodness, where the council wants to look at what it's commissioning, look at what it's paying. We're doing the whole cost of care national reform exercise. And the conversations around that, to me, feel more open and transparent on both sides. I think that collaboration that grew up born of necessity during the pandemic. And Helen's right, we were collaborating before. And Helen was talking to my board members, certainly, about wanting to develop a truly co-production approach to everything. And then the question is, how do you do that and make it meaningful? And actually, the pandemic solved some of that because it forced everybody together to do that. And I think we have a really strong basis to do proper co-production where, as Helen has just described, where really early on, before any decisions are made, the conversations are had together rather than the old model, if you like, which is the council would come up with a plan and then go out to consult with its service users and its providers and whoever else about how it wanted to do that. We don't see that anymore. That's stopped happening. And the conversations happen at the kind of, absolute grassroots level about where we are, what's the art of the possible, where do we want to get to, and what are the stages that need to be put in place to do that. And so that, to me, feels like a sea change in a way, from that old idea, consultation, decision making, whether you like it or not model that was the kind of classic, I suppose, way of doing things.
Thanks, Joe. And I think Emma wanted to add something as well.
Thank you. Yes, what I really just wanted to add was that the collaboration actually went much further than thinking about Wiltshire Care Partnership and the providers and us as a council. And I think that the work that's described in this paper was much broader in terms of how we're working with our GPs, our community health colleagues. I think the care home advisory group that is referenced in the paper and was stood up at the start of the pandemic was a really strong example of that. So that gave opportunity for Wiltshire Care Partnership to represent their views to colleagues from AWP, from the CCG in a much broader way than they'd ever had the opportunity before. And that multi-agency approach in terms of health, social care, and all aspects of that coming together was certainly very more innovative for us and has led to those strong relationships that will support us going forwards in how we do support those very vulnerable residents. We are seeing people in our care homes now who have a very, very complex set of needs, whether that's physical or cognitive. And actually those multi-agency ways of working have led to some of those interventions being much more multi-agency and effective. So I think it just wanted to flag the kind of broader collaboration rather than just us as a local authority and the providers.
Thank you, Emma. And did we have any further questions from the committee? No, in which case we'll move to a resolution to thank Councillor Davies and officers for the report, to note the positive relationships that have been developed with providers during the pandemic, and to commend the collaborative work that significantly accelerated with Wiltshire Care Partnership and System Health Partners in response to the challenges of the pandemic. Could I have a seconder for that? Gordon, thank you. Any objections? No, in which case that's moved, and we can move on to item 9 on our agenda this morning, which is an update from South West Ambulance Service Trust. We have a report in the papers from SWAST, which provides some local data relating to current and recent performance levels for the ambulance service supporting Wiltshire. I believe that we have Jess Cunningham joining us online and Paul Burkett-Wenders as well. Do we have Paul?
Good morning. We're just waiting for Paul to join.
Paul's joining us shortly. Okay, well, welcome, Jess.
Thank you.
So before we open up for questions, Jess, are you happy to lead on highlighting the salient points within the report, and particularly anything Wiltshire specific?
Yeah, I'm very comfortable to do that.
Great, and Paul's just joined us as well. Yeah, perfect. Okay, thank you.
Okay, would you like me to pause for questions, or would you just like me to?
I think perhaps if you introduce the report, and then we'll open up to the committee for questions after that. Thanks.
Okay. Thank you very much. So my name's Jessica Cunningham. I'm the Executive Director of Operations for South Western Ambulance Service. And I'm joined today by Paul Burkett-Wenders, who is the County Commander for BSW. Okay, so in terms of the report, I'll just highlight 7 things for the committee, and then we're happy to take questions. So I'll structure this in terms of the report, so you'll be able to follow it, I think, as I go through. So the first thing is around our activity. As a trust, and it's mirrored in BSW, we've had our activity is currently broadly back to pre-pandemic levels, so around the sort of the 1920 financial year mark. But in the intervening 2.5 years, we've had very high activity spikes at intervals, which you can see from the report. But as a trust, and certainly within the county, we're broadly back to pre-pandemic levels. The second highlight from ourselves is that we have worked over a decade on reducing conveyance to hospital wherever we can. And so it's been a programme of work within our ambulance service for quite some time, at least a decade. And we're currently the leading ambulance service in the country for not conveying people to hospital. So currently we're conveying around 40% of our patients to an emergency department. In some areas of the trust where the handover delays are particularly acute, then it's slightly lower than that. Pre-pandemic, we were conveying around half our patients. So there's been about a 10% improvement in people that we take into the emergency department. So we are confident as a trust that we're doing everything we can in regard to that space for the system. And there's a graph in the report that you'll be able to look at the trend of the non-conveyance rate. The third item is around our resourcing hours. So again, the report covers this, and there's a graph in there to illustrate what we've been doing. Over the last 5 years, we've been on a programme to shift the amount of conveying vehicle capacity within our fleet. So if we roll the clock back 4 years ago or so, we would have had about 80%, 75 to 80% of our fleet as a conveying capacity, which are the ambulances. So enabling us to take patients to hospital. The rest being cars, or what we call RRVs. We flipped that. So we're currently at around about 97% of our fleet is conveying capacity. And that's something that the ambulance service as a whole across the UK have been striving to do, because it means that we are flexible and we can use a resource to respond to the patient in the best way. So we're really pleased with the progress on that. The funded levels in BSW, we're currently putting out slightly more than our funded levels, but that's in response to some of the hours we're losing at hospital, which we'll come on to in a moment. But for your assurance as a HOSC, we are putting out our funded level of resourcing, and we're topping that up. And in fact, that's mirrored across the trust. So in recent weeks, we've agreed to invest in further resourcing to help mitigate some of the problems that we're experiencing currently. BSW is similar in many ways to the whole trust position. So as an ambulance service, we're funded for around 24% abstractions at any one time. An abstraction is an absence from work, and it can include annual leave, sickness, maternity, etc. We're currently around sort of early 30s, and we have been as high as 37% in BSW. But that was when we had a lot of staff off with COVID. We are starting to see an uptick in that most recently, but we are making good progress on just bringing some of the abstraction pressures down, which obviously helps us get the resourcing out on the road. I'd just like to move on to handover delays. So there's a section in the report that covers this and goes into some detail in relation to the hospitals within your area. So just to illustrate what's happened as a trust, we used to lose somewhere in the region as a trust about 400 to 500 hours a week of delays. So that's operational time lost to handover delays. We're currently at around 8,500 hours lost across the trust. So there has been a very significant deterioration in the southwest, and currently we have 6 of the top 10 hospitals in the country, unfortunately, losing the majority of handover delays in the southwest. In your area, so in April 21, we would have lost about 150 hours a week of delay time. In April 22, it was 1,600. So quite a considerable shift as well in your area, although in recent weeks that has started to come down. And just finally from me, and I'll hand over to Paul in a minute just to see if there's anything Paul would like to say. We've received a set of system trajectories to reduce the amount of handover delays in the southwest. So we've received trajectories from each of the 7 systems within the southwest. BSW have submitted a trajectory which sees handover delays reduced by 70% at the end of June. So we're currently not meeting that trajectory. And in fact, we're not meeting that across the trust either. So from our perspective, discussions are still in track to understand better from the systems what actions they are putting in place to make that sizable reduction for us. And if we can do that, we can improve response times, because there is a direct correlation between handover delays, operational time lost, and the response times that we can deliver to patients. Okay, I'm just going to hand over to Paul now, just to see if there's anything you'd like to pick up, Paul. Thank you.
So I will say there is a good working relationship between ourselves as an ambulance service and the local commissioning group in terms of the CCG, and also the free acutes within the BSW area. So there is a shared understanding of the problem and the severity of the problem, and we were working obviously in partnership to try and improve that. But some of the sort of gains have not really been seen there. So the ambulance service and the emergency department are really like the front line of healthcare, and some of these problems stem from the wider system. And so in the hospitals there, I think one of the major factors for these delays is the non-criteria to stay. So essentially people who are ready to leave the hospital, but difficulty moving them outside of the hospital into the system. So it is a wide system problem we recognise. And you, as you will see from the graphs, when we lose the time to handover delays, that has a direct impact on patients and our response time. So you may have heard from some of your communities a sort of delayed response, and you can see the very clear link there in some of the graphs that have been provided. And I will say that has an impact on our staff as well. So they are managing patients in the back of an ambulance who perhaps waited for a long time for a response for a period of up to 5+ hours. So obviously that's an awful experience for the patient and difficult for our staff to manage. So we have to deal with some of those impacts there. We are hopeful that there is this trajectory has been set, as Jess mentions, that we will be able to strive to achieve some of those reductions in handover delays, because as you can see from all the information you've been presented with there, it does have a direct link to the quality of service that we as a complete system are able to provide to patients.
Thank you. Thanks, Paul. Just to reiterate some of the things that Paul said, the service that we're providing currently is not what we joined the ambulance service for. As Paul said, this is a system issue. There are good relationships in this county, but the fact of the matter is that the handover delays are leading to extended response times, and you can see some dreadful waits for patients in excess of 10 hours in your community. It is taking a toll on our staff as well. So, we have crews that are doing one or two patients per shift. Sometimes we have crews that come back to the same patient after they've been off shift in some of our other areas. So it is having a really detrimental impact on our staff, and they talk about skill decay and just not having the skills to look after patients for that amount of time. That they're experts in pre-hospital care, they're not nursing staff. So there are different skills there, and it is an issue across the southwest for us. Just to end on a positive note, we are really hopeful, and we welcome the trajectories that have been submitted by the systems. We just now need to see that translated through into action and a reduction in our delays and a release of our ambulances. Okay, thank you. We're really happy to take any questions.
Thank you both very much for the report. And, we do as a committee recognise the systemic nature of the problem. And earlier in the meeting, in the chairman's announcements, I did announce that we are looking to have an inquiry day to look at the system-wide pressures on that, which we'll be organising to hold probably in the autumn. I'll open up to the committee for questions then. Councillor Cape.
Thank you, and thank you very much for that very helpful report. And I absolutely support what you're saying, that it is a system issue where the ambulance performance, it becomes really a symptom of what's going on. I wonder if you could just clarify really, on page, I think it's 28 or 29, you've got that chart of the trajectory, 29, of trajectories, I can never say that word, I wonder if, just clarify, I think I'm understanding that these are targets set by those different communities. Thank you.
Yes, I'm really happy to do that. So each of the 7 systems within the Southwest were tasked with submitting a trajectory which shows a reduction in the amount of hours lost to handover delays. So if we just take one of them as just an example, if we take Devon, which is the top line, the top yellow line, what they're saying is that they will reduce their handover delays. And you can see if you follow the line target down, by October, they're almost sort of at minimal levels. So each system has submitted these on behalf of their system, and it reflects a back catalogue of actions that they're taking. So they've made a judgment about when an action will have an impact in terms of reducing the handover delays. So you can see each system have responded differently, but they all show a sizable reduction. And if you add that up for the Southwest, it's an 80% reduction by next March and around about a 70% reduction from the 1st of October. So hugely significant. And if the systems are able to deliver this through the action they are taking, it will have a remarkable impact on our response times. The key issue for the ambulance service is our level of confidence in the action that's being taken and the reduction that we're seeing. So if I give you a for instance, in June, so at the end of June, looking at the trajectories all added up for the Southwest, we should have been at 6,380 ambulance hours lost for the month. We were in fact at nearly 8,500. So we are around about 2,800 hours difference, and that is 1 month in. So that is the current discussion on the table. To what extent is there confidence that the actions that are being taken will lead to this dramatic reduction? I hope that answers your question.
Yeah, Claire, did you have a follow-up on that?
Yeah, that really helped. Thank you very much. And I think my follow-up question was going to be, I think you partly answered it, to what extent has the very recent nudge of improvement been due to actions or just a reduction in demand, or it might be a combination of both, or difficult to say, but any comment on that would be really helpful. Thank you.
Yeah, so I'm happy to take that from a trust perspective, and then I'll hand to Paul, because I think there's a local dimension to all of this, and not all systems are the same. So I think there's variability across the Southwest. There are some systems that have submitted brand new actions that they're going to be taking to reduce the handover delays. In some systems, they're focusing on actions they're already taking. So in terms of our degree of confidence, it's really looking at what new action is being taken in a system which has a direct line of sight. And the problem with healthcare very often is that there are multiple factors affecting a reduction or an improvement, and you can't draw a direct line of sight, which is where it becomes difficult for us to answer the question about our confidence. All I can point to currently is across the Southwest at trust level, we're not meeting this trajectory. Paul, do you want to just talk more locally?
Yeah, so in the last 4 weeks, in particular across BSW, we have seen about a 10% drop in activity prior to the 4-week period before that. So clearly that helps. There's less patients within the system. And we've been working with the BSW CCG and the hospitals for some time. So some actions are already in place, and we've been doing things for a while. And I suppose the one of note that I would draw your attention to is the navigation hub that they set up at GWH, which we're a part of, and a coordination centre to try and tackle some of the patients who are going to be entering the hospital system and make sure that they are navigated to the right place. So potentially that means not going to the ED itself, but to other services. So that's a better experience for the patient and reduces some of those handover delays. So there are some work in train, and indeed a key aspect of the trajectory you've just seen there for BSW is to expand the coordination centre, so it's not just in Swindon GWH, but across the whole of the BSW area. So I think that some of the actions are in train, and that's sort of some of the detail behind some of the future actions as well.
Thanks, Paul. Any further questions? Councillor Vigar.
Yeah, so the response times, I was just looking at that chart, it appears to be quite a way above the national average, but I also see that there are a lot of places which are worse, and so maybe the national average is a little bit skewed in itself, in that some places have got very, very low response times. I just noticed that London, for example, and East Anglia, it's far worse than South West. The response times here, to what extent are they being driven by the handover times? And to what extent is it just a function of the nature of the South West and it being a sort of rural area and taking a while to get to places? Or are there other factors I've not spotted there? And I suppose, just to go on the handover, what is driving that handover problem? Is it an administrative problem? Is it a staffing problem? Or is it actually literally having to get somebody out of the back door of the hospital before you can put somebody in the front door?
Okay, thank you, David. So there's two parts to that question. I'll take them in turn. So in terms of the first question, to what extent are handover delays driving our response times performance? We have evaluated it many times, and they are the single largest factor that are leading to our response times, particularly the lengthy delays. So pre-COVID, when we had handover delays in the sort of 400 to 500 hours per week mark, the South West, it was not unusual for us to be delivering a category 2 mean of 20 minutes, 25 minutes, and we were delivering category 1 performance of 7 minutes across the South West, which is no mean feat when you consider our geography. In the last 2 years, with the handover delays increasing to the extent that they have, so 8,500 hours lost last week, which is a quarter of our resourcing for the whole of the South West being lost, it is having a very detrimental impact on our response times. There are other factors, such as activity comes into play, but that's not really an issue currently because we're sort of back to pre-pandemic levels. The South West receives an awful lot of visitors in the summer, and that will lead to overloading some systems. But from our perspective, and it's been evaluated and confirmed, handover delays are the single biggest factor impacting on our handover delays. And you can see, I think from the information we've provided, there are a couple of graphs in there that track handover delay and response time performance together, and you can see that the lines match pretty well. There's a high degree of correlation. In terms of the second part of your question, what is driving handover delays? I think it's different in different systems. Some hospitals have got real staffing challenges and are really struggling to staff their own emergency departments without then spending, time and effort on trying to get us into the hospitals. So we know that because we're being asked to staff cohorting areas in some hospitals. So these are areas where patients are taken into a sort of a pre-emergency department space and looked after by and large by a paramedic, supported sometimes by the hospital staff, to provide that sort of halfway house and to get the patient out of the ambulance into something resembling, more a sort of acute care. So we know that the hospitals are having staffing challenges, and I think it's affecting all of healthcare. One of the things that the hospitals tell us, and we have got absolutely no reason to doubt this, is that the impact of social care and places that they can discharge patients to is having a significant impact on their flow and operations. So, at any one time, there are hospitals in the South West that have 3 and 4 wards full of people who have been assessed as ready to leave hospital, but who can't because the packages of care and the support required means that they can't be discharged. And all that happens is it then backs up to the front door, and what you see on the TV and in the media is an expression of that. It's ambulances queuing outside of hospital, 15 to 25 ambulances. So that is, in my view, and based on what the executives in the hospitals are telling us, is one of the main contributing factors to the handover delays. Paul, did you want to add anything from a local perspective?
I think you're absolutely right, Jess. And I think if you look at the graphs that you've been provided, you will see both Cat 2 and Cat 1 response times, which I think is the red line, increase dramatically when we have handover delays. You did mention the rural aspect of it in terms of the county. My son played cricket on Sunday against Chalk Valley, a beautiful part of South Wiltshire. But I was just astounded when I was driving there and back that it is incredibly rural, and it made me think, how can we make sure we get a timely response to people there? So there is that component of it, but it is the handover delays, and I think that is really clear for you to see when you look at those graphs. And the hospitals, it is the non-criteria to stay patients. They are literally in the hundreds each day at RUH and GWH in particular, and that system-wide approach. And it's not just a simple case of these people can go somewhere else. It's the care package that they require, and the different pieces and different parts of the system working together. So that is a major factor, I think, for the hospitals. But yes, absolutely, it's handover delays at the moment, and you can see that, I think, quite clearly.
Thank you both. Further questions from the committee? No? Okay. Well, absolutely. I think the inquiry day will enable us to focus a lot more on these systemic pressures, both with potential delayed transfers of care, but also issues with people who perhaps would be better off in primary care instead being directed to A&E. This also is an element that we need to look at. Yeah, no, and thank you both for the presentation. We'll resolve then to thank the South West Ambulance Trust for the report, to note the systemic pressures placed on the system, and to agree that we will hold an inquiry day this autumn to look at those system challenges. Thank you both for your time today.
Great, thank you very much.
Okay, can I have a seconder for the resolution? Thank you, that's moved, unless there are any objections. No, thank you very much. Okay, we'll move on then to item 11 on the agenda, which is urgent items. I'm not aware that there are any. Are there, Kieran? No. Oh, sorry, sorry. Item 10, apologies, I'm getting ahead of myself. Forward work programme. The forward plan is attached in your papers for information. Can I invite any comments on that plan? No, okay, in which case I'll move that we note the plan. Could I have a seconder for that, please? Gordon, thank you. Any objections to that? No, that's moved. Thank you. And we'll move on then to item 11, urgent items. Not aware that there are any. No, so I'll move to the final item on the agenda, which is the date of the next meeting, which is at 10:30 in the morning, 15th of September, back here in the Kennett Room at County Hall. So thank you all for your time this morning. And I wish you all a nice summer, which looks like it's finally arriving outside, which is good. And we'll see you all in September. Thanks.